biparametric versus multiparametric MRI for prostate. For prostate cancer.
Good afternoon. I would like to discuss biparametric versus multiparametric MRI in cancer prostate detection. I would like to acknowledge Assistant Lecturer Aliaa for her effort in her master's thesis. Prostate cancer is the second most common cancer diagnosis made in men and the 5th leading cause of death worldwide. It may be asymptomatic at the early stage and often has an indolent course, and it presents in men, elderly men above 65 years of age. Regarding the anatomy of the prostate, we can see the prostate here from base to apex, and it is, according to the PIRADS version 2.1, it is 41 sectors. We have here in pink the peripheral zone of the prostate, in green the central zone, the transitional zone in yellow, and the anterior fibromuscular stroma in blue. Regarding the normal MR anatomy, we have on T2 weighted images, the peripheral zone is normally T2 hyperintense, and the central zone consisting of the central gland and the transitional zone is hypointense. 70 to 75% of all prostate cancers originate in the peripheral zone, and 30% originate between the transitional and the central zone, as well as the anterior fibromuscular stroma. Here's an example of pointer ازاي بالماوس. Okay. Here we have a prostate cancer in the right peripheral zone of the mid prostate. Okay, and this shows low T2 signal and diffusion restriction with low ADC value and restricted diffusion. The PIRADS reporting system started being implemented in 2012. Okay. It was implemented in 2012, and then it was modified in 2015, giving a second version where MR spectroscopy was not implemented. And then in 2019, there was a second version, version 2.1, with minor changes in the assessment of the transition zone lesions. The PIRADS version of reporting the prostate goes like the PIRADS 1 is very low incidence of clinically significant prostate cancer. PIRADS 2 has low incidence. PIRADS 3 intermediate probability of prostate cancer. PIRADS 4 and 5 is high and very high probability. Regarding the assessment of the peripheral zone, in version 2, it was determined that the diffusion weighted sequences are the most important to diagnose peripheral zone lesions. So if the peripheral zone had no diffusion restriction, this was reported as normal, PIRADS 1. If there is very low or indistinct hypointensity, it's PIRADS 2. If it's moderate or mild hypointensity like this area, so it's PIRADS 3. And then PIRADS 4 and 5 is markedly hypointense and marked diffusion restriction. Less than 1.5 centimeter is 4, and then more than 1.5 centimeter is 5. Then here comes the role of the dynamic contrast enhanced images. When we have a PIRADS 3 lesion, we look at the dynamic images. If it is negative for early focal enhancement, it becomes still PIRADS 3. If it's positive, the lesion is upgraded to PIRADS 4 lesion. Regarding the assessment of the transition zone, the main sequence is T2. So we have the normal appearance of the prostate. This is PIRADS 1, and then the adenomatous nodules, which are well encapsulated, is PIRADS 2. It has to be properly encapsulated all along. And then the heterogeneous lesion with obscured one or more margins would be PIRADS 3. 4 will be a lenticular, non-circumscribed, homogeneous area of low signal intensity on T2, less than 1.5 centimeters, and then more than 1.5 becomes PIRADS 5. After assessing the T2, if the lesion is scored as 2, we have to look at the diffusion. If we can give it a score from 1 to 3, meaning it is not markedly hypointense, it retains the score 2. If it is markedly hypointense, it is shifted to 3. The lesions which are scored as 3 will be moved to 3 or 4 according also to the diffusion criteria. So in our study, we were assessing biparametric MRI because the value of dynamic contrast enhanced MRI in the detection of prostate cancer is still debatable, and biparametric will facilitate a more rapid examination, a safer examination with no intravenous contrast and less risk of nephrogenic systemic fibrosis. It will be a less costly exam, and it will be easier for the patient who stays for a very long time on the machine. In clinical practice, some have viewed the dynamic contrast enhanced images as a safety net or a backup sequence when the diffusion images are degraded. So if you have a good quality diffusion weighted images, some readers do not need the dynamic contrast images. The aim of the work was to assess the biparametric versus the multiparametric in prostate cancer detection. The study was done in Ain Shams University hospitals with 41 patients. Inclusion criteria were patients with digital rectal examination positive for prostate cancer, elevated PSA, and all patients underwent prostatic biopsy or radical prostatectomy. The exclusion criteria were the patient who had contraindication to MRI, contraindication to contrast injection, or degraded diffusion-weighted images, or unavailable pathology results. Consent was taken, and the patients had proper general and local examination. The sequences done were T2 weighted images with small field of view for the prostate in axial, sagittal, and coronal, diffusion weighted, and ADC. It has to be high B-value diffusion, 1,400 or 1,600, and dynamic contrast images in addition to the T1 weighted sequences for the bone and lymph node metastasis. Image interpretation was done by 2 radiologists in consensus, blinded to the pathology and blinded at first to the contrast-enhanced images. They scored the lesions according to T2 and diffusion, and they gave a PIRADS score. Then dynamic contrast-enhanced images were assessed, and it was given a multiparametric score in consensus. Our patients ranged in the ages between 45 and 83 years. The total PSA ranged from 8 to 575. The PSA density, which is a very important marker for the probability of prostate cancer, meaning that we divide the total PSA by the volume of the prostate, and above a certain cutoff value, this is likely to be clinically significant for prostate cancer. Our mean PSA density was 1. There was statistical significance between the PSA levels and the PSA density between cancer patients and non-cancer patients. We did a ROC curve for the PSA density, and our cutoff value was more than 0.6 in differentiation of cancer from non-cancer patients, and the cutoff in literature is 0.2. The percentage of patients with cancer were 61%. The Gleason score of the cancer was 4 plus 4 in 56% of the cases. It was 4 plus 3 in 36%, and 8% had 3 plus 4. The location was in the peripheral zone in 84% of the cases. There was statistical significant difference in ADC values between cancer and non-cancer patients. The cutoff for the ADC value in our study was 0.7. So less than 0.7 ADC was considered malignant in our study. The seminal vesicles were invaded in 77.5%, in 22.5%, and the metastasis was found in 15% of the patients. Regarding the dynamic contrast score, it was positive in 73.2% of the patients. Regarding the percentage of patients which were scored differently in biparametric than in multiparametric, they were 10 patients were scored as PIRADS 3, and in multiparametric was only 1, and 4 patients were scored as PIRADS 4, and they were 13 in multiparametric. So the multiparametric scored identically the patients in 20 of the 25 patients with prostatic cancer. So 9 patients were upgraded from PIRADS 3 to PIRADS 4 according to dynamic contrast images. 20% of the cancer cases were upgraded when adding the dynamic contrast enhanced images. The area under the curve for biparametric and multiparametric was nearly the same, 0.953 for biparametric and 0.950 for multiparametric. So we can conclude in this study that if the cutoff value was used as a PIRADS 3 lesion, the biparametric and the multiparametric had exactly the same sensitivity, specificity, positive and negative predictive value. But when the cutoff for prostatic cancer increased from PIRADS 3 to PIRADS 4, the sensitivity and specificity of the multiparametric was slightly better than the biparametric. We have a few cases. This was a 68-year-old male patient with bilateral flank pain. Here we have the diffuse low signal in the peripheral zone of the prostate. You can see it posteriorly on T2 weighted images. Regarding the seminal vesicles, they were both infiltrated with loss of the high signal in the seminal vesicles. They're diffusely low. The right vesiculoreteric junction was infiltrated by tumor, and there were bilateral malignant-looking obturator lymph nodes. The ADC value and the diffusion, there was marked restriction, and here the ADC was markedly low. So here in this case, the PIRADS score was given according to the diffusion as PIRADS 5. The dynamic contrast enhanced images were positive for focal early enhancement within the peripheral zone of the prostate, but this did not change our PIRADS score, so it remained as 5. And in this case, the dominant sequence was the diffusion, and the patient was diagnosed by pathology as adenocarcinoma, Gleason score 4+4, which is a high-grade score. Another case, a 50-year-old male complaining of difficulty in micturition, total PSA was 8. Here is a lenticular area of low signal within the right peripheral zone. When you look at diffusion, there was moderate diffusion restriction and moderately low ADC value. And this was scored as PIRADS 3 by biparametric MRI. When you add the dynamic contrast enhanced images, there is focal early enhancement within the area of diffusion restriction, and this increased the score from 3 to 4. This lesion was pathologically proven to be benign prostatic hyperplasia with prostatitis. Another case is a 49-year-old male with bilateral loin pain and a PSA of 78. We can see here a heterogeneous low signal intensity ill-defined lesion in the left anterior transition zone. We can see corresponding diffusion restriction, which is marked, associated with low ADC value. So this lesion was scored initially as PIRADS 4. By adding the dynamic contrast enhanced sequence, there is no evidence of focal early enhancement in the left anterior transition zone, so the PIRADS remains as PIRADS 4. The lesion was pathologically proven to be adenocarcinoma, Gleason 3+4. There's another case of a male 55 years old with total PSA 5. There is a faint triangular area of low signal within the peripheral prostate bilaterally. On diffusion, there is indistinct hypointensity bilaterally and indistinct diffusion restriction, which gave the lesion a PIRADS 2. Of course, in PIRADS 2 lesion, the addition of contrast does not change the scoring. Here was positive focal early enhancement, and the lesion remained as PIRADS 2 with benign prostatic hyperplasia and prostatitis as the final diagnosis. The last case, a 72-year-old male with prostatomegaly and also high PSA. There is a diffuse infiltrative lesion within the prostate, anteriorly, posteriorly, spanning the apex to base within the peripheral zone. Here there is multifocal diffusion restriction with markedly hypointense low ADC value within the lesion. So the dominant sequence was the diffusion and it scored it as 5. By adding the dynamic contrast images, it was also early enhancing, and it did not change our diagnosis as PIRADS 5. The patient's histopathology was adenocarcinoma, Gleason score 4+4. The study had limitations, the limited sample size, no clinically insignificant cancers were included. To conclude, the biparametric without diffusion did not lead to significant differences in diagnostic accuracy in our study, so this gives us a reasonable case to use biparametric MRI for routine prostate MRI and reduce the costs and the gadolinium-based agent-related risks. But we recommend that the biparametric should be used as with cutoff of more than 3, and the patients with PIRADS 3 could be closely followed by MRI or could undergo initial biopsy, which gives comparable results and exactly the same accuracy as multiparametric MRI in this setting. Thank you.
بشكر دكتورة علياء على البرزنتيشن.